Good afternoon, friends. Welcome to the Department of Medicine academic lunch. We have two excellent speakers for you today. Dr. Samuel Hansdak is the professor and head of Medicine Unit 4 in CMC Vellore. His interest is lifestyle medicine, and he has trained in lifestyle medicine as well as sociology. Our second speaker is Dr. Herb. Herb is our faculty of Medicine 4 as well. He works with Sam, and he also takes part in lifestyle activities in Medicine Unit 4. And they have various projects and plans for lifestyle medicine. So we are really blessed that we have the two best speakers possible to speak about lifestyle interventions in medicine. Today's topic is a serious one, diabetes, which causes so much morbidity and mortality in India and in many developing countries. The topic today is reversing diabetes with lifestyle. It may seem strange to reverse a disease which we thought was not curable, but there are some excellent reviews. A recent review is there, Reversing Type 2 Diabetes, in the journal Nutrients by Sarah Hallberg and colleagues, where they say it is possible to reverse some amount of diabetes. So it is a difficult topic and a difficult thing to achieve as well. But today we are going to hear more about reversing diabetes through lifestyle. Once again, I request all viewers to, at the end of the session, to stay behind and keep your questions ready, where Sam and Herb can answer your questions. And thank you for joining us for this session. Thank you again to Sam and Herb. Thank you to Mohan and the telemedicine team for helping us to get this arranged. So with that brief introduction, I'll hand you over to Sam and Herb. Thank you.
Good afternoon, friends, and thank you, Dr. Tambu, for inviting us for this session. I'm a little nervous looking at the numbers who are joining, and I hope we are able to do justice to this topic. A disclaimer right in the beginning, we don't have any claims of what we can do, but we'll humbly try to go through the literature as it says and some of the experiences that we are having as we incorporate lifestyle as a part of our practice of treating patients. So diabetes, as we all know, we are looking into is reversal a myth or a truth. It will be in two parts. I will be doing the introduction, the definition, and pathogenesis, and Dr. Herb will be covering the management. Looking at the epidemiology, I think all of us are familiar. Diabetes is the leading cause of death globally, with 1.6 million cases, very next to HIV and tuberculosis at 1.5 million. There is 1 in 11 people who have diabetes, and 1 out of 2 diabetics, one remains undiagnosed. The global prevalence has jumped from 4.5 to 8.5 from 80 to 2014, and 1.6 million deaths are directly caused by diabetes. Another 2.2 million deaths attributable to high sugars, and 75% of patients with diabetes live in low and middle income countries. And these are something of our concerns, because we always thought diabetes was a disease of a upper socioeconomic state, but we really are struggling with diabetes just covering up. India is the second highest numbers of diabetics from the age of 20 to 79 years. And if you look at the changing prevalence of type 2 diabetes in India from 75 to 2014, this is the rural populations where only 2 states had a little amount of diabetes, has spread all over. And in the rurals, in the urban setup, as expected, the numbers have really gone up. So the issue is, what is diabetes? I guess you know what is diabetes, but the more you study about diabetes, you really start scratching your head to say, do I really understand what diabetes is? Is it just high sugars? Is it just related to some insulin issues? Or is it more than that? And we are going to take that journey to start understanding. Last week we had a wonderful session which encouraged us to do critical thinking. Look at the facts, look at the processes. You may have some feelings, you can come up with some creativity. Be cautious to look at the benefits. So we are going to look at some of those approaches. How do I look at this disease, which we think we know, And the other thing that was brought up last week was also about root cause analysis. Going to the root of it, there was a wonderful illustrations of how we go into the root. Step 1 is to define the problem. Step 2 is to determine the causal relationship, identify the effective solutions, and then get down to find solutions into track. So what is the question? The question is, what is the cause of diabetes? We think we know, but then the literature speaks so many things, we start getting confused. What is the cause of diabetes? And 2, is it possible to reverse it? So let's look into it and see what we can find out. There are a lot of books and claims that goes around: cure diabetes, reverse diabetes, diabetes undone, end of diabetes. Is it really true? Diabetes is from irreversible to reversible. People having claims of 6,000 diabetics being off insulin, off medication, are these real? If you look at the diabetes milestone, started somewhere in 18s, where we realized that diabetes was because of pancreas. In 20, we identified the insulin. And after that, there's a whole lot of development with drugs, delivery systems, and latest now we are looking at islet cell transplantations and things like that. And very interestingly, in 1939, the American Diabetes Association, look at the vision statement. The mission of the ADA is to prevent and cure diabetes. 1939, the target was to cure diabetes. The vision is life free of diabetes. But look at our statistics. We are completely overwhelmed by the increase. Do we really understand what diabetes is? Are we anywhere close to achieve this objective of curing diabetes? For whatever reasons, they thought we can cure diabetes. They have not removed this objective. Is there cure diabetes? So our responsibilities, can we move towards that goal? So let's look at the term. What is reversal versus remission means? Reversal as defined by them is a disease implies that whatever was causing it is now gone and is synonymous with using the term cured. So reversal is essentially saying cure. What it means is that you can eat your standard diet and maintain normal sugar without medication or therapeutic diet. Only then you can say it's reversed or cured. And what diet? I mean, no comments. Standard American diet is also called a SAD diet. The term reversals came up in our literature when we started bariatric surgery. Very impressive results. 85% of them had blood sugar being normalized within weeks. And the mechanism thought was decreased GIP, which decreases insulin resistance, and increased GLP-1, which increases insulin levels. But this is the longest follow-up of the bariatric surgery. After 2 years, very impressive, 72% had normal sugars by definition, but on 10th year and 15th year, you see it dropping to 40% and 30%. So as much as we wish we had a cure, maybe if the medicine people were not able to find the solutions, our surgical colleagues were helping us in giving us a solution, but you see it's still far in the horizon. What is remission of diabetes? There's an evidence that indicates that if there's a weight loss of about 15 kgs, you can result in remission of type 2 diabetes symptoms, and that beta cell function can be restored to some degree so that the dormant beta cells get reactivated and existing beta cells can function better. So in 2009, ADA defined remission as being able to maintain normal sugar below the diabetic range without currently taking medications. They went on to further subclassify it as partial remission, complete or prolonged. Partial is if it is less than HbA1c less than 6.5 and a blood sugar between 100 to 125 fasting. Complete is if you achieve less than 6 with a fasting sugar of less than 100 for 1 year, and prolonged is if it is more than 5 years. So you can understand reversal and remission, the implications are different. The only connotation over here is what is that standard diet. So I guess this is something that all of you are familiar with. Diabetes we define as fasting more than 126 and post-parental more than 200. And pre-diabetes, either it's the impaired fasting glucose means fasting between 110 to 125, and postprandial less than 140, and impaired glucose tolerance as fasting less than 110 and postprandial being 140 by 199. So if you look at the pathogenesis, just to revise an anatomy, the islet cells in pancreas, and what we look at the islet cells, the way it looks in histopathology. So we're looking at 4 cells, alpha cells, beta cells, delta, and the F cells in the endocrine part of the pancreas surrounded by the exocrine cells. And we are focusing on 2 cells, the alpha cells which secretes glucagon, the beta which secretes insulin, and a myelin acts insulin by effectively slowing the intestinal absorption of glucose and suppressing glucagon. So a myelin helps the function of insulin in regulating the rate at which glucose is absorbed. And if you look at the beta cell, the glucose enters through the GLUT2 receptor, and as it enters, it triggers off various activities within the beta cells in a result of just to enhance the secretion of insulin. And this insulin, when it comes to any cell, we have an insulin receptor and you have a gate. I mean, this is just a schematic gate for us to understand that when the insulin sticks to its receptors, it opens the channel for the glucose to come in. So that is one part. The other is for us to understand the gut and gut's response to the control of sugars. And when we eat, we have 2 incretins, hormones which are secreted, the GIP and the GLP-1, and these then acts on the pancreas. It is basically to reduce the blood sugar by mobilizing sugars into the muscles and the glucose. This is finally controlled by the DPP-4 enzyme. So when you have the sugars coming down, they start degrading the GLP and GIP just to control the amount of sugars in the blood. Now, what is the difference between GIP and GLP? And this is something for us to understand. They basically stimulates insulin secretion and does all the things that insulin does, except GIP causes increase in glucagon as compared to GLP, which causes decrease in glucagon. When the sugars are high in the blood, glucagon should be low and insulin should be high to move the glucose. But GIP, it increases glucagon, and this glucagon causes fat lipolysis as a part of gluconeogenesis, and that fat increases the adiposity, and this leads to insulin resistance. So basically, the pathogenesis of diabetes are hinging around 2 concepts: the insulin resistance and the relative impairment of insulin secretion. So it begins by insulin resistance, insulin level goes high, and over a period of time, because of hyperinsulinemia and increased glucose, which also causes glucotoxicity, there is an impairment of beta cells, and these 2 things finally leads to diabetes. So the body weight has been long associated with hyperinsulinemia, and we see the impaired glucose, and with time the sugar starts going up. Just one more thing to understand is half the diabetics are undiagnosed at any point of time. So that's one thing. Type 2 diabetes has been associated for long with obesity, hypertension, and dyslipidemia, labeled as metabolic syndrome. And the predating of insulin resistance before glucose goes up is something that we have known, but we all wait for glucose to go up and start treating it, and that is something that should bring into my mind, what about the insulin? Should we be treating insulin? Does insulin levels cause any damage? And metabolic syndrome, hyperinsulinemia, we know that the pathogenesis has already begun there. Hyperinsulin is related to, I'm just magnifying the adipocytes, and what it does is, it's not just a passive deposition of fat in the cells, but these cells start releasing various inflammatory cells, which causes most of the damage. And so we find there's increased free fatty acids, adipocytes, cytokines, and oxidative factors, and all these things causes the pathogenesis related with diabetes and also with hyperinsulinemia. So people who eat more, exercise less, nutrient intake with increased metabolic activity, increased adiposity. With these fat, you have a low-grade inflammation, reactive oxygen species, dyslipidemia, adipokines and beta cell stress. These are the ones that contributes towards insulin resistance, and over a period of time, it leads to beta cell dysfunction with relative decrease in insulin, and then there's a mobilization of glucose from liver and muscles causing diabetes. One more aspect of the whole process is looking at the gut microbiome. When we look at the gut microbiome in people with different dietary patterns, you find that on a plant-based diet you have high secretions of short-chain fatty acid as compared to the TAMO, and we'll talk about it. And what this does is that most of these are nitroso compounds which causes DNA damage, increase in the cytotoxicity and genotoxicity, as compared to those with a plant-based diet has increased short-chain fatty acid which tries to repair the damaged processes. And trimethylamine N-oxide has various pathogenesis from metabolic syndrome, atherosclerosis, and the CKD progress. So again, when you have a high fatty meals, there's a decrease in the short-chain fatty acid, LPS and branch-chain amino acids increases, and all these contribute towards the insulin resistance. And so if you have to put everything together, diet, physical activity, mental stress, all of these leads to microbiome dysbiosis, oxidative stress, cell injury, and all these leads into chronic inflammation, and CVD, diabetes, cancer, depression and anxiety, obesity are all a part of the understanding when we put it all together. So when we look at these, somewhere the behavioral changes in the brain which makes us do what we do in turns gets augmented by the various biochemical changes that happens within our blood and body, which again reinforces our brain to do what it does. So it's a complex mechanisms that keeps going on. And in this slide, I'm just trying to show that as we understand the metabolism of glucose in our body at different levels, from our gut to the pancreas to the various cells, the muscle cells and the liver, you find that we have tried to get various drugs at each level, trying in a hope to control. But you realize there are so many things that you have to control, whether one drug or a combination of drug. Is there a better way to do it? And so I stop here by saying health as defined by WHO is not just an absence of disease, but a state of complete physical, mental, social well-being. So what we are proposing is, can we have a holistic approach to the understanding of a person and change in different domains, from our nutrition to our diet to the mental stress? If we do that, is it possible that we can achieve a normal homeostasis? Can we achieve a remission? Can we achieve a reversal? And so at this point of time, I hand it over to Dr. Herb, as he will talk about what are the things that we can do. Thank you.
Good afternoon. It's a real honor for me to be here with you. I really look forward to these Department of Medicine meetings and appreciate being on the receiving end. And this afternoon, as we continue to share about diabetes reversal, I hope you find it useful for you as well. Now, Dr. Samuel George already talked a little bit about remission, and also with bariatric remission, we see that there are accounts that it can be quite high. In the first 2 years, even up to 70, some people say up to 80%, and then it drops after that, all the way down to the 30% at about 10 years. But it's really quite remarkable, and it was with bariatric surgery that we saw the literature that diabetes could be or could go into remission. Carter et al. Did a study looking at remission with the with usual care. And using the same definitions that Dr. Samuel George gave, they showed that in their population, they had about 1.4% of partial remission, 0.14% of complete, and 0.07% of prolonged remission. Now that sounds like it's almost hopeless. If you multiply those numbers by the number of people that have diabetes, it creates a substantial number, but it's still not an exciting or encouraging number to be thinking about as far as reversal without bariatric surgery is concerned. If you look at the whole cohort, you see that it got up to 1.6%, and if you look at those that had just had diabetes in the last 2 years, it was up to 4.5%. Now, a recent review of the literature looked at a number of studies that were focused on remission. Their initial review actually got about 900 hits, and then once it was weaned down, it had, I think it was 59 hits, and then for those that were really relevant and focused on the topic, it ended up being about 9 hits. I think there's a few more that weren't found, but they really did a very nice job. And as they went through the literature, they said, look, it's very clear that there are some studies which are more successful and some studies that are less successful. And it seems like the dose really matters. And that often we say, we tried lifestyle and it didn't help. But many times it may have been a very subtherapeutic dose rather than a therapeutic one. To illustrate, if ourselves or a patient has a splitting headache and what we have available to us is aspirin, we would probably give 325 to 650 milligrams of aspirin for the headache. However, if instead of that we take a baby aspirin, which is used for as a thrombolytic, 75 to 81 milligrams, we'd say, we took aspirin, it didn't help my headache, therefore let me do something different. I think many of us look at lifestyle in the same way. We see that we've tried something, or we really weren't sure what to do, how much to push, and exactly what to do, and so we quickly give up and move to medications or other means that we have been taught more in our UG and maybe PG programs. We have some very good studies. We have the one by Lean, the direct one, and many of these studies, as Dr. Samuel George has already mentioned, have focused on weight loss as being one of the key ones. And here you can see for the top 5 studies in the row, it says that they really had a therapeutic effect. If you come over here, you can see that there was anywhere between 20 to almost 300 subjects or participants in each of these studies. You can see that weight loss was one of the targets because the caloric intake ranged between 600 up to 1,500 calories. We then see that on average, that overall they lost about 21 kg. Sorry, between 11 and 33 kg was the range for 19.5. And following the definition that Dr. Samuel George gave earlier, the remission rates were between 42 and 100%. And for complete remission, it was between 46 and 100%. You can look down here at the subtherapeutic studies, and they only list 4 of them here. And you can see that one of the studies shows a complete remission of somewhere between 11 to 3.5%, and then partial remission between 13 and 43%. And so you can see that that with these studies which lasted anywhere between here we have 8 weeks. Sorry, here duration. Okay, I thought we had 1 or 2 here that were for 2 weeks. it's not uncommon to have a 2-week study, but here we have 14 weeks and 2 years, and below that is up to 4 years. Now, just a reminder again that most of the failures, it is felt, are due to inadequate dosing of lifestyle medicine, not to any inherent deficiency of the treatment. Now, Roy Taylor, he has really been a pioneer with remission, with our counterpoint studies, and one of his recent papers showed that the remission of type 2 diabetes requires liver and pancreas fat content, a decrease in liver and pancreas fat content, and that remission is also dependent upon the capacity for beta cell recovery. And what he shows is that out of a population of diabetics, when you put them on treatment, and in this case their primary treatment here was weight loss, that you have some who are responders and some who are not responders. And those who are responders, they don't end up having the return of the glucose control back to the non-diabetic state. However, they may be able to eliminate their excess fat in the liver as well as the pancreas. Now, in this program, they lost on average about 15 kg, and they said that if you lose at least 10% of your body weight, that is usually very helpful, and you have a good chance to have remission. So we have the weight issue, and there are some studies. There's a couple which also look at, can we have remission without weight loss? And Dr. Anderson did one of those, but before we come to Dr. Anderson, I'm just going to mention Dr. Kempner. He was a professor of medicine at Duke University, and he was really working in the 1940s and 50s on especially hypertension, but he also did some with diabetes associated with vascular disease. Now, he was famous for his rice diet. Now, his rice diet was a little bit unusual in the sense that 94% of his diet was carbohydrate, 4% was protein, and 2% was fat. And the diet was made up of rice, fruit, and sugar. But you couldn't add additional salt, and you could have other flavorings, but not that were caloric or had salt in them. Now, out of 100 consecutive patients, you can see that they followed up from a minimum of 3 months up to 11 years, and the diabetics were either freshly diagnosed or had been diabetic for up to 33 years, and the age range was 19 to 71, about half male and half female. On this kind of diet, we would have expected that the insulin requirements would have gone much higher, and for some patients it did, but on average we see that the fasting blood sugar dropped from 202 to 155, the insulin needs dropped from 25 to 17, blood pressure also dropped on average. A number of these patients also had dilated cardiomyopathy, and we can see that their heart-chest ratio also decreased, their weight decreased, and even their diabetic nephropathy and diabetic retinopathy, for some of them, improved, which was quite amazing. Now, Dr. Anderson, he did a study with 20 young men and showed that he had these diabetics eat enough to maintain their weight, and they really struggled. But when they did that, they also saw that with his kind of diet, that their glycemic numbers also improved. He also did quite a few studies in the 1970s, and one of the studies that he did was among 10 diabetic men. It was a 15-month follow-up. 7 were on insulin, 3 were on sulfonylureas, 6 were lean, 4 were obese. Average age was 48, and their mean duration of diabetes was 7 years. Now, what he did was he admitted them to his metabolic ward in the hospital, and he put them on a weight-maintaining control diet for 5 days, making sure that they got their insulin, they got their sulfonylureas stabilized very well, their blood sugars were stable before they embarked on his intensive phase of study. And you can see here that for the weight-maintaining control diet, it was 43% carbohydrate, 20% protein, and fat, and 37% fat. Now, he did what many people today are also doing. He had both an intensive phase and a maintenance phase. He kept his patients in the hospital for the next approximately 13 days. And during this intensive phase, he also put them on serious education. He encouraged them to also be active with exercise 15 to 30 minutes after 2 or 3 meals. You can see that his fiber dose or recommendation that he had for his patients was higher than our usual fiber dose. It was up to 75 grams. And he also provided a detailed dietary booklet, which he gave them when they went home so they could continue to follow up. In there, he also had instructions on how to buy food, what to eat. He had tables on how much fiber there was, what the fiber energy ratio was, and for many of the patients during the first week on this new intensive phase, they were not able to eat all the food because you can see here that with the fiber being so high, it's being 70% carbohydrate, 21% protein, and 9% fat, that the bulk was a lot more than what they were used to. Now you can see from his intensive phase here, he also markedly dropped the caloric intake from fat down to 9%, and many people see this as being very important today, and a lot of programs really limit and restrict fat as well. That's an area that we don't have the best answer for, but it seems clear that if you have an intensive phase where you can help to decrease the fat in the diet, that it will also help the liver and the pancreas fat content to also decrease. Following his 13 days, he then sent them home, and on their home maintenance program, the physician, nurse, and dietitian followed up every 4 to 10 weeks, and you can see here that he liberalized the diet a bit. He maintained his 75 grams of fiber, but he decreased the carbohydrates, he increased the protein, and he also increased the fat. And on that program, we see that all of the patients, their labs stayed the same as baseline, though they had many of them had a decrease. After 15 months, there was only 1 on insulin and 2 were on sulfonylureas. Triglycerides were lower. The weight had an average 11-pound loss that really was influenced by the 4 obese patients he had. And all 10 subjects found that program to be very well acceptable. No one dropped out. Their major difficulty was the fat restriction and the restriction on meat intake. And so the question comes in about the ketogenic diet. The ketogenic diet is one that we are finding many people really like because we see rapid weight loss, we see rapid glycemic control, and because things are happening quickly and we like to see results, many people really like it. Now, we also are discovering that the ketogenic diet is becoming a spectrum as well, along with a paleo diet, and there's many different varieties, and so we can't label everything to be exactly one with one specification. But we see that in general, the ketogenic diet does emphasize a low carbohydrate, high fat, high protein eating pattern, and with this eating pattern, the body is forced to metabolize fats instead of carbohydrates. the diet is not energy deficient. Now, if they are eating less food and losing weight because of an energy deficiency, it may help them some, but if it is not energy deficient, we see that it does not reverse the liver or the pancreatic triacylglycerols, and thus it helps. The serum glucose is improved, but not the insulin resistance. And so we see that the ketogenic diets, they appear to eliminate diabetes, and they make us feel good that the blood sugars are well controlled, but we don't give our beta cells a chance to be challenged with carbohydrates. And so rather than improving and restoring the beta cells, we are protecting them from being challenged. One question comes in about plant-based diets and versus animal-based diets. And what we discover is that there are a number of other very good meta-analyses as well, which look at meat intake, and there seems to be some a correlation with meat intake and diabetes. It is weaker for fish, and some studies have shown that it is also weaker for chicken, but other studies are showing that for chicken it is also present. Here we can see that with this meta-analysis, we had ranges from as low as relative risk of 0.38 all the way up to 0.84, but an overall effect of 0.77. And I don't quite understand how they figured it out, but when this association was then strengthened when they added in fruits, vegetables, whole grains, legumes, and nuts as part of their definition of plant-based patterns, and then that dropped it down to 0.70. And when and with other manipulations, they found that it may be as high as 0.8. So it's about 0.77 according to this meta-analysis. So the issue then comes back on fat. It keeps coming up, and what we have here is Dr. Lackey has a very splendid study looking at dietary fat and how it potentiates insulin resistance. Now, what he did was he took 4 groups of mice, and with 2 were lean mice and 2 were obese mice, and 2 groups, okay? And each group had 8 mice. Now, what he did was he fed the 2 lean mice groups a low-fat diet and a high-fat diet, but a diet to maintain their lean body mass. For the other 2 groups, he also gave them a low-fat diet and a high-fat diet, and this time he overfed them and increased their intake by 185% of calories with time. And in order to do that, he had to insert a gastric feeding tube so that he could be feeding them constantly. Now you can see that for the mice here, their macronutrient composition was, for the low fat, was the same amount of protein, but for the low fat mice were fed about 9% fat and about 40% for the high fat diet mice. And the carbohydrate content ranged between 65 down to about 34%. And what you can see here in A, and if you look closely, you'll see that the lines with the squares represent the LFD is the low-fat diet, OVF is overfed mice, and the HFD is the high-fat diet, overfed mice. And you can see that both groups of mice, they became obese. And for the regular fed diet mice, both of them maintained their regular diet. Now, if you look at graph B, what you will see is here he looked at blood glucose, and the high-fat diet overfed mice I have put here in red on top, and you can see that their blood sugars were up and higher, and then here we have the, I'm sorry, yeah, and then in yellow we have here the low-fat diet overfed mice, and I put that in yellow here to make it a little bit easier. And we see what we expect, that those on the high-fat diet, their blood sugar goes up. In fact, even the one on regular diet that was high-fat, their blood sugar was also, it went up a bit, and then it came down at 90 minutes. If you look at the insulin intake, I'm sorry, the insulin that's produced, we see that for both of the overfed mice, at time 0, the low-fat diet overfed mouse had a lower insulin level, but it was higher than the 2 regular fed ones. But at 10 minutes out, it was about the same as the high-fat diet overfed mouse. Now, he then did a number of other studies on them, looking at inflammatory markers, but then he comes over here looking at blood glucose, where what he did is he now has 5 groups. The last 2 weeks of the study, he crossed his low-fat diet overfed mice and gave them a high-fat diet. And the high-fat diet mice, he crossed them over and gave them a low-fat diet diet, but still overfed them. And so what you can see here is that I've overmarked it in yellow, the low-fat diet regular. So that is kind of our baseline here. Then we have the low-fat diet overfed, and you can see that the blood sugar initially went up, but once the once they had the high-fat diet, we can see after 2 weeks their blood sugars were higher. Now, if we look at the one that started out with a high-fat diet and then was switched to a low-fat diet, we see that 2 weeks later their blood glucose is coming down and is much closer to the baseline that was there before with their glucose challenge. So in summary, from his studies, nothing surprising. He shows that excess calories cause obesity, whether it's high fat or whether it's low fat. He shows that obese, high fat diet mice, they get insulin resistance. Low fat diet mice are more glucose tolerant even when they are obese. And that the high fat diet and obese mice have increased inflammatory markers. So I thought it would be useful just to see what does the ICMR and the global burden of disease studies show. If I am looking for the ideal diet, and I'm here in India and I have diabetes, what should I eat so that I can minimize my risk of death from diabetes? And you'll notice that the first thing is, up here, is to increase whole grains, to increase nuts and seeds, and to increase fruit. So if I have a diabetic patient and they say, what should I do? This is one area that we can ask. And for most of us, I would suspect that eating whole grains in a day or in a week may not be very often. Nuts and seeds also may not be that often. And fruit also may not be that often. The other factors here for our behavioral risk factors include smoking, physical activity, alcohol, and then down here at numbers 8 and 9, we had our sweetened beverages and our processed meats. So the power of plants, getting enough whole grains, nuts and seeds, and fruit seems to be where things are. Now, as we look at food in general, we know what all of the components are, and many times we focus on macronutrients. And one of the things that we're discovering is it may not be the macronutrients that's so important as the whole food. And so in this illustration, we have food categorized into three categories. We have what's called farm plant food, which basically means food that comes as grown pretty much from the farm. And this includes what we all know as our vegetables, our fruits, legumes, whole grains, tubers, nuts, and seeds. As we look at the nutrient density, we see that it's high. Fiber is high. Water content of the food is high. Phytonutrients are high. Antioxidants are high. Fat is low. Calorie content is low. And for the planet sustainability, it's also high. And what we see is that these foods also are high in color, which lets us know that they also have many different phytonutrients that may be helpful for us, and that we should try and be eating a variety. And what we discover is that we do have more healing and health promotion with these foods. Now, one of the biggest concerns that we have with diabetes is heart disease. And I bring this here because not only do we see that a similar type of diet has helped to reverse heart disease, but here with both Dean Ornish and Esselstyn, Dean Ornish, he had a less than 10% fat diet for his program, and Esselstyn is very strong that in his program, everybody is eating only whole plant foods and no refined foods and no animal foods. Now, this also seems to be somewhat relevant to us here, because in the same ICMR global burden of disease studies, if we look at the deaths attributed to diet from ischemic heart disease, we see that it comes to about 70% in 2017, which suggests that 2 out of every 3 Indians who die of ischemic heart disease are having their death attributed to diet. And so that may be an issue that we may need to look in and explore further. The second category of food that in this illustration is what's called factory foods, or processed or refined foods. And as we look at these, we see that nutrient density in general is low, fiber is low, water content, unless it's a beverage, really is almost nothing. Phytonutrients are low, antioxidants are low, fat is typically high, and calories are high. And our third category of food is what we call animal foods and products. And we all know what these are: our fish, our chicken, milk, eggs, cheese, the things that we all love and that taste so good in the mouth. As we look at nutrient density, some people will say, yes, this is fantastic food, it's very important. Others would say, I'm not so sure. So we put an arrow on both sides. Fiber, we know that in animal foods there is none. Water content, there is some, and it's more than there is in refined foods, but it's still less than what is in the plant foods. Phytonutrients are 0, antioxidants are low, fat is higher, and calories are higher, and plant sustainability is low. Now, what's interesting is if we compare these, we see that for the factory and the animal foods, that there's almost an opposite characteristic from the farm foods. And from that perspective, we see that things are something to think about. It makes it a little bit easier for us to understand possibly why we may be having more insulin resistance coming in as well. We mentioned earlier about some of the inflammatory and endothelial markers. And in this study, it looked at inflammatory markers of CRP, interleukin-6, homocysteine, and endothelial markers of activation. And they used four different diets, with the first diet being largely fats, processed meats, processed foods. We saw that 3 of the markers were elevated. When we added veggies to our fish and red meat, only 1 was elevated. When we added beans and tomatoes and refined grains to our red meat and our high-fat dairy, it even went in the opposite direction. And then when we had all whole plant foods, we saw that we had a much better picture. And that the more whole plant foods we had, the less inflammation and the more healing. So the question is, many people say, when I eat that kind of food, I'm never full. And it's interesting that studies have shown that satiety is determined by weight. And so those people who are eating more plant foods will eat larger bulk, and those foods which have water naturally in them are also more filling. To be drinking water with your meals, it doesn't have the same impact as if the water is integrated into the food. And what we discover is that if people can eat a low energy dense diet, they have much less restriction in that category. And so one of the recommendations is, can we encourage early in life dietary preferences in the lower energy foods, so that would help our kids as well as us in the family. Again, looking at the power of plants in diabetes, we see here from the Adventist Health Study that the more plants we eat, the less diabetes prevalence there was in their study. And the question is, we don't know the full explanation, but it seems like it's partially due to lower energy dense foods, higher fiber, maybe more nutrient density, higher phytonutrient and antioxidant intake. So this is something else that we see also. The DASH diet was originally created for hypertension and stopping hypertension, but a lot of people are also use it in diabetes. And Dr. Sachs, when he was creating the diet, he noticed the power of plant foods for treating blood pressure, and so was trying to create a diet where he could maximize the power of the plant foods and make the diet more acceptable to others. As we look at diet, one is, what is the type of food? Two is, what is the timing of food? And three, what is the amount of food? So whether you want to call that TAT or ATT or some other acronym, and the amount we've already seen, obviously if I'm eating extra calories, I will get obese. The type of food, if we can be eating more plant foods, and then the timing of foods. We're seeing a lot more studies coming in about the timing of foods. I'll just bring in one quick study here. In this meal timing study, Dr. Kelly had 6 individuals in a random crossover design where he put them in his metabolic chamber there at Vanderbilt University. He had a schedule where they had breakfast of 700 calories, lunch, dinner, and then a late evening snack. And then there was a 14-hour intermittent fast before the next morning's blood test. And so one group had this diet, and on the one side in the morning they only had plain tea or coffee, and then they had their lunch and dinner and the heavy late evening meal. The second group, they had their late evening meal snack in the morning and no late evening meal. And what you can see here is that the late evening meal, here we have in their carbohydrate oxidation grams burned. We see that in the red, there is less that is being burned with their carbohydrate at night after 8 o'clock. And then we see that for the one that is eating a strong breakfast and missing their late evening snack, they're burning more carbohydrate. As far as lipid oxidation is concerned, we see that those that are eating the heavy breakfast and skipping the late evening snack is burning more fat at night. In this study, it was about 15 grams. So what they showed was by minimizing their evening meal, they were also able to have small, but over time it makes a difference, decrease weight gain. Now, so in general, as we summarize, as far as macronutrients, it seems like we really do not know the exact protein, carbohydrate, and fat concentration that people need. We do have many groups, and there isn't much literature yet that I have seen that talks about having fat being less than 10%, like Ornish initially did in his study in 1990. He has, I think, agreed to liberalize that a little bit. Some people are saying up to 15%, some people are saying up to 20%. The studies, I mean, the recommendations or criteria for low fat is less than 30%, and high fat is above 30%. So there really is no good study that is showing low fat diets like this and comparing them with other diets when they're whole plant foods. Micronutrients, we know that we all need. We've already mentioned the microbiome and nutrients. And now one newer concept here is the water content that is naturally in foods, which seems to be important. Again, the type of food, the timing of food, and the amount of food. And the other question is, as someone is wanting to embark, should they embark gradually or should they go for a full immersion? And what we see is that many times if we have only a subtherapeutic dose, that may not be enough for us to reverse disease, but it may be enough for us to prevent disease if we're not already there. There isn't time right now to talk about exercise, but we also see exercise again with time, with type, time, and the amount. And what we're discovering is that not only do we have our duration of exercise, we also have being active immediately after meals, and we also are discovering that we have high intensity interval training, which also makes a big difference for our glucose control. Sleep is another big issue that's emerging. We won't spend much time here, except that in this new paradigm here with Dr. Nicholas, where in the past we looked at drugs as our primary place of starting, and then we added exercise and diet, and said, then sleep. Now the recommendation is let's make sure our patients are sleeping well, adding a diet and exercise, and then drugs as needed. We can see here that sleep is a big factor, either with restriction or fragmentation, that can lead to decreased brain glucose utilization, adipocyte dysfunction, sympathovagal imbalance, increased inflammatory cytokines, alterations in cortisol and growth hormone pattern, and increased nocturnal and free fatty acids, which altogether give us some beta cell dysfunction, insulin resistance, and lead us to diabetes. And sleep is something we haven't thought probably enough about. So the promotion of adequate sleep duration could improve our inflammatory state, oxidative stress, and our antioxidant capacities, and act together to prevent or improve early cardiometabolic dysfunction. So in brief summary, we really want to look toward making diabetes remission our new goal in standard of care. We want to be cautious about our excess calories because they drive our insulin resistance, leading us to diabetes. We see that remission is dependent on the normalization of our hepatic and pancreatic fat, and a return to our non-diabetic glucose control depends upon our beta cell function. Lifestyle is the key. When we look at diet and the different parameters, type, timing, and amount is important. Our ideal macronutrient mixture seems to be less important than having a plant-based focus, and having a lower fat intake or a weight loss. In most of the literature, it says 5 to 7%. In Dr. Taylor's recent work, he's talking about up to 15%, especially for overweight people. And again, we come back to the 10 kilogram amount that is mentioned in his literature as well. And so from last week, we were encouraged to lose 10 kg. So let's keep the idea of 10 kg in our minds there as well. So I want to thank you all. There's many more things that could be said about diabetes and other aspects of lifestyle, but I think the diet component is probably the largest.
Just responding to the questions that have been flowing in, just want to kind of summarize diet, as Dr. Herb has pointed out. People often talk about two major groups of diet, that is Ornish and what's his name? And keto diet by Atkins. So Atkins and Ornish are two groups of diet. So Ornish is basically a carbohydrate-based diet, and Atkins is basically a protein-based diet. The whole concept of protein-based diets came up saying that diabetes is a problem of sugar, which comes from carbohydrates, which make logical sense to cut down the carbohydrates, replace it with proteins and fats. And so that is how the Atkins diet came up. And Ornish said, no, I mean, it's just that you need to eat the right type of carbohydrates. You definitely, what is refined is bad, what is complex is still good, and that is generally a part of our diet. Even in our Indian scenario, most of our food is basically carbohydrate. Interesting study in 2014 in diabetology, they have looked into whole grains and incidence of diabetes, which is a prospective study. And what they have found is that people who took a larger amount of grains as a part of their diet had lower incidence of diabetes developing. And so that carbohydrate diet, most of the studies are based on carbohydrate diets, which has been found to control diabetes and keep it under control. So between a carbohydrate and protein based diet, most of the studies are showing that it is a carbohydrate based diet that we recommend for our patients, because you are cutting down on the fat. And if you make your diet as protein based, depends on what is your source of protein. If it is a plant protein, you may still have less fat, but if your protein source is animal, you will have a high amount of fat that will be coming with your protein based diet. And as we looked into the pathogenesis, it's the fat which causes insulin resistance and all the other diseases as a part of it. So the move is still towards cutting down on fat, cutting down on saturated fat, which comes from the animal source. Plant-based diets are unsaturated, and that is, if we have to use it in moderations. Dr. Herb has given us the percentage in different studies that they have used. So basically, we are talking about a carbohydrate-based diet, which we can call it as Ornish diet. We are looking at fat as a content, as mentioned, less than 15%. And I think some of the things that has come up, the usual things that comes up, what about milk? If you're looking at even to up to date, there's an inverse relationship between dairy consumption and the prevalence of diabetes. So that's something that is also now documented. Very interestingly, milk has never been shown to increase or protect osteoporosis for the single reason that we take milk is as a calcium source. But there's no epidemiological study which shows that that actually reduces. Rather, some of the study shows there may be a little increase in the incidence of fractures, osteoporosis related. So milk basically will still have saturated fat, and the saturated fat is the main reason of a pathogenesis as we understand. And so we would even American Heart Association has also come up with guidelines saying restrict dairy and poultry products, because those are again the source of saturated fats, which enhances the process of atherosclerosis. Anything you want to add, How? I think some of the questions that is coming on intermittent fasting. You want to share?
Sure. I think that fasting is very important. Unfortunately, there wasn't time for me to bring that in here as well. Kaliova et al. And one or two other studies have come out showing that actually for glucose control, we actually do better on 2 meals a day than on 3 meals and 3 snacks. So this whole area of diabetes and diabetes remission is actually an area which is ripe for many PG theses. And so I think that there's a lot that we can do here in our center as well, and exploring some of these, because dogma around the world is 3 meals and 3 snacks. It's not just India, it's the US, it's everywhere. But what we're discovering is with the idea of remission, the less frequent we eat, probably the better. We also are discovering that if we can avoid our late night meal, and if we can even make our evening meal finished even by 3 o'clock, let's say, and that is very helpful. So I see fasting as being important for everybody, and there's different kinds of fasting. The first kind of fasting is fasting between meals, and that's something that we still have to struggle with our current diabetes dogma. The second kind of fasting we have is where we have a prolonged overnight fast, or some people may call it intermittent fasting, which I think is very important. Some people also find that fasting once a week is very helpful. Now, if you're on glucose-lowering medication or insulin, you need to work closely with your doctor and see what works best for you. The challenge is if a person moves to plant-dominant diet, which is not excess in calories and is decreasing their feeding interval, even if they're eating a similar amount of calories, that can also be quite powerful in dropping their need for medications. And so whatever a person does, they really need to do it together in cooperation with their physician. So fasting, I think, is very helpful, and we also, I think, are discovering that more and more it even gives us a chance to potentially even rest our pancreas a little bit, and there may be some healing benefit there possibly.
So just a little addendum to that. I think the latest study, which was a case report in BMJ of 3 men fasting and reversing diabetes, has become a big talk of the town. Everybody is looking at it, but the scientific community is making it a little cautious of how we interpret it because it's 3 people. But the concept is that you need to lead a normal life and you need to have a normal practice, and how within our normal practice we can do things which restores back to normal instead of doing certain things, you know, on extremes. Intermittently trying to do some things is fine, but the usual pattern that we would advise, and that is again 2014 Diabetology has did a study on 2 major meals versus the traditional advice of 3 major and 3 minor meals, or 6 meals for all diabetic patients. They have done that study, and in that study they felt that the glycemic control and the compliance to that was much better than when you put them on 6 meals a day. Now, one of the physiological understanding of that is, if a pancreas who is not able to function well, do you give them more work or less work? A person who is a diabetic who is struggling in the sugar controls, the more you feed, the more pancreas has to secrete insulin. It's over a period of time. If you look at the natural history of diabetic, most of them after some time require insulin, which we accept it as a natural history, but it could be possible that we are pushing them towards that by increasing it. The reason why we add on snacks is because you want to prevent hypoglycemias, because these people are on medications and the tablets will not fine-tune the dose and the levels based on the food and the sugars in the blood. So you create a normal physiological sittings by introducing few snacks in between. Now, till long, it was just accepted as it is till that study came up to say that you actually can put them on 2 major meals, breakfast and lunch, and a very small snack kind of a dinner. And the study shows their glycemic control was much better as compared to the controls of people who are there. So one is the type of meal, the frequency of meal, introducing fasting. Fasting, there are almost 5-6 types of fasting which people have described. Take the first meal between 10 to 12, the second meal between 4 to 8, 2 meals a day. Some people do fasting alternate day. So there are different types of fasting they have described, and people are trying to do studies on it. And I guess those things will become much clearer as they are subjected to various scientific studies. But one thing that has been associated with longevity consistently in all studies is calorie deprivation. The people who live with lowest calories seems to live longer than people who take more than what is required. And so that is just as an overarching statement. But looking at it, the studies that we have together with us is we are just trying to put it together. One of the questions asked here is, what about spirituality and its impact on diabetes? Stress is very clearly associated with inflammations and even hormonal changes, all catecholamine going up. All of them tends to push up your sugars as a part of gluconeogenesis. And so anything that reduces stress will definitely lead towards normalizations of blood sugar control. And so when we are looking at stress, different people have different methods of coping with their stress, spirituality being one of them. And so definitely there's a role of spirituality for people who believe in God and would take that as a support system to alleviate their stress, definitely it will have also an effect on the physical part as in diabetes control.
Question comes in about elaborate more on the role of exercise. Actually, exercise is typically can do as much as an oral anti-diabetic medication. We see that for diabetics, they really need probably at least 60 to 90 minutes of actively walking per day. We're discovering that walking after meals is really quite powerful, and that really can also help to drop the postprandial glucose as well as the A1C over time. We're seeing that high interval intermittent training is also very good with lowering blood sugar, but also exercise. Probably the biggest role is with helping to reverse insulin resistance. We see that with our lipotoxicity in our muscles, we have extra fat there, and as we start out, the way to get rid of that fat and burn more of that fat is with exercise. We also see that one of the big challenges that we have is our new disease called sitting disease. And whatever we can do to not be sitting all the time and having prolonged episodes of sitting, even having a strong exercise program will not counter the effects of prolonged sitting more than 4 hours a day, 8 hours a day. So, and the recommendation is, can we get up every half hour or maximum every hour for a couple of minutes and be on our feet? And we see that that also helps glycemic control as well.
I think we can see a question coming. What is the ideal amount of oil intake you recommend? If you ask Dr. Herb, he'll say 0 oil, and there's actually no need to add oil. More and more evidence moves towards an ideal setting of eating whatever is in the raw form, what is edible raw, because most of your nutrients are best packaged in that sense. The more you cook it, more you lose the nutrient. Of course, you can't eat everything raw, but one is, so the fruits and vegetables, the salads and the sprouts, everything comes within that form. The more you take it in that form, it helps. It adds on bulk, and so your total amount of appetite also comes down. The oil, let me put it this way. Basically, oil you classify as plant source and animal source, saturated and unsaturated. What is healthy is the unsaturated, which comes from the plant source. And within the unsaturated, you have the monounsaturated and polyunsaturated. Is a mono, which is the healthiest, and those are the olive oil and canola oil, as compared to the polyunsaturated, which is the most popular sunflower and other oils which are there. So if you have to look at the best oil, which has the highest amount of MUFA or monounsaturated, followed by polyunsaturated, followed by saturated. So olive and canola comes under that. Second thing is, you also would be aware of the cis and the trans fatty acid. And as much as unsaturated are healthy, if it is in the cis form, that's a healthy. The moment it becomes trans, it becomes unhealthy. And how does an unsaturated becomes trans? Is by heating and by hydrogenation. And so that's a typical way we cook our food. The oil goes first in the pan, and then the rest of the food come. So as much as you may be using a plant-based oil at home, but the fact that you heat it and sometimes reuse the same oil, because you don't want to throw away things that you would have cooked some nice, delicious fried things. The more you heat it, the more you're converting into trans. And so trans is something that is bad for our health. And second is, when you hydrogenate it, most of the snacks you like it crispy, and that crispy taste is because the oil is hydrogenated and made solid. And so that again makes it unhealthy. So if you have to ask, if you have to use oil, between these oils you choose the best oil. Preferably use it as it is without heating, but ideally do not take it in an oil form. Olive oil is good. Why not eat olives? Why not eat peanuts instead of taking a peanut butter or taking oil out of it? Same as somebody has asked a question on coconut oil. Coconut oil also is going into a lot of controversies. People say drink it and use it in different ways. That's the only plant oil which is high in saturated fatty acid. But the good about it is it's got a medium chain fatty acids which are actually good. So I would say eat coconuts. Don't try to take out the oil and then use it in different ways. The more we get into a habit of eating food in its whole form, you have the health benefit of it as compared to when you process it. Refining, processing takes away the nutritive value.
One other part there about oil is that it seems like the more we are sedentary, the more the oil we eat becomes the fat we wear. And so I think that we need to be careful about that. The other part is if you are diabetic or if you are trying to lose weight, I would encourage you to experiment and try and go on an oil-free fast. Now, what I often do with my patients, I challenge them, can you go 2 weeks or 1 month on this dietary pattern? Because if I ask you or you ask me to make some abrupt changes and say, this is the way you will live the rest of your life, many of us will say, forget it. But if we can try and experiment and say, well, let me give it 1 month and see what happens, if we can do it as a family, and then see how I feel, how my blood sugars are doing afterwards, that makes it easier. 2 meals a day, won't this increase the amount of food I take at a meal? It might, but that usually is not a problem. Well, what we have discovered, for example, is that if you are eating 2 meals a day, especially if it's whole, more plant-based foods, that even if you're eating more, many people will even lose weight, especially if they're eating early in the day rather than late in the day. In fact, when we have someone that says, I'm eager for diabetes reversal, we put them on a full plant-based diet if they're ready for that, and tell them there is no limit in quantity to how much you eat. You can eat as much as you want for the next 1 month, but only at mealtime. Nothing between meals. And what we see is that the volume that we eat is also significantly more because it's less energy dense.
How many calories deficit is ideal for weight loss and diabetes? As Dr. Herb says, I mean, most of the time the calculations doesn't really work out as much as we tell our dietitians, give them a 1500 kilocalories. But you see, if you add on more fibers to the diet, the more bulk, so these are nutrient sparse food as compared to the nutrient dense food. So if your lunch, I mean, the usual strategy we tell them, take a bowl full of salads and eat it before your lunch. So once they eat the salads, the stomach is full, the amount of the main course that they will take will automatically come down and they would not feel hungry. For me, the most important is that they should not feel hungry. That feeling of hunger will make them go snack, and one snack is equal to almost 2 meals. That's how energy dense they are. So the main important is to keep them full, and keep them full with things which doesn't add on calories to them. So by simply increasing the amount of non-digestible food like raw foods in form of salads and sprouts, you can easily cut down on the main course and the calorie comes down. And that's one thing that you can do for most of your patients. Role of blend of oil, rice bran and sunflower. There are questions on sunflower and bran oil and cold pressed oils. So again, all these are oils, all these are processed. They do all kinds of processing, advertising it different ways. I would say for any particular delicacy you want to use a little oil for that purpose, that's fine. But for your day-to-day diet, I would say take food in its whole form and as steamed, if you have to cook it, as baked, some people may like it, or raw, and start getting used to that taste. I think that itself will take care of the constituents, and the total calorie automatically comes down, and they will start losing weight, and all the parameters will start getting better.
Another question comes in about vitamin D. Actually, vitamin D has been a bit controversial in the past. what we just had a fairly new article published, which and there's others also that suggest that those people who have normal to normal high vitamin Ds, 50, 60, may have a hemoglobin A1C of up to 0.5% lower. So we will be learning more about that here in the near future. But vitamin D may become a standard part of our regimen for our patients as well.
I think there's some questions on sleep. The usual prescription for sleep is early to bed and early to rise makes a man healthy, wealthy, and wise. As something that we have heard since our early childhood, science seems to say that the early we sleep, how early is kind of for each one of us to think what is practically feasible. But basically, as the sun goes down, our pineal gland is sensitive to light, and as the light stimulus goes down, the pineal gland starts secreting melatonin. The high surge of melatonin gives you a very good night's sleep, and melatonin is not just for sleep, but studies are showing depressions, cancers, and many other disease associations are seen where melatonin is low as compared to people whose melatonin is high. So if you have to ask what is an ideal sleep hygiene, the ideal sleep hygiene is that, one, your dinner should be early, your dinner should be light. Some people may just take some fruits early by 6, 7, and no stimulants, means tea, coffee, and the biggest stimulant in the evening is television, mobile, and laptop. And these keeps us active, keeps us awake. The brain is awake, the pineal gland is shut down, the melatonin is at the minimum. You lie down in a bed and you struggle to get sleep, and you wonder why. And so if you understand the basic physiology, not just telling anyone else, most of us are doing that, but somewhere we have to make that habit to put down everything, maybe after 7, 8, whatever we can afford for. Whatever you want to do in the night, do it in early morning. When you have rested, your mind is fresh, you can do the same work much faster and more quicker. So the sleep hygiene is, so early dinner, light dinner, no stimulants, sleep early. During sleep time, just make sure that the room is pitch dark. Even your chargers, if you see in the dark room, looks very bright, and that light can also affect your melatonin secretion. So usual thing is it should be a pitch dark room. That means you draw your curtains. There should not be any lights. If you're living close to roads where vehicles would be passing, even those strips of lights that comes in can also affect it. And so ideal would be is that sleep hygiene that we would encourage all of you to follow. And most of the healthy diets also have found to push up the melatonin levels and give you a good restful sleep.
Regarding naps, we all need, or most all of us need, about 7 to 8 hours every day. If we can get that at night, best. If we can't get that at night for whatever reason, and you get it through an afternoon nap, that's better than missing it. So get the sleep that you can get when you can get it, but ideally if you can try and get it at night, that's the best. Another question here about timing of walking. There's lots of studies, lots of discussions. Probably most people would say that if you're eating more of a low-fat, plant-based diet, and you're walking not more than maybe a brisk walk, you can do that right after you eat. People are talking about a half an hour to 1 hour starting after when you begin eating. I'm not sure it really makes much difference. In the past, we were much more concerned when we were eating a high-fat diet. If I go out and exercise, will I have a heart attack? But when we see that if it's more of a low intensity and/or more of a plant-based, low-fat diet, there usually isn't anything to worry about in it. And Wes Youngberg, from his experience, he says that for every minute of walking after meals, the blood sugar typically drops between 1 to 3 points. So if I walk 10 minutes after a meal, my blood sugar may drop between 10 and 30 points. And what happens there is that not only does it drop, but it stays down, and so the curve is blunted, and so your A1C is also improved.
That's true. So I think keeping yourself physically active throughout the day is important. Dr. Herb said sitting disease, you should not continuously sit for more than 30 minutes. That's the recommendation. If you're sitting in the OPD, get up, drink a lot of water. That will make you run to your restroom. That will keep you walking. So water exercise keeps happening. One of our faculties stopped using his chair. He had a elevated desktop in which he kept the computer. Even standing gives you enough of calorie burn that you need if you're not able to walk. So there are different things that you can do. We have a good physiotherapy, occupational therapy department. They can also help us in many of those things that we do. I am reading is catching up sleep during the afternoon nap. A short nap in the afternoon, keeping in mind if you sleep a little longer, a little too much in the daytime, that may affect your nighttime sleep. So that's something that you may need to kind of work it out. If you're really tired, you need a little nap. A short, quick nap shouldn't do harm.
They generally say less than 30 minutes if it's...
Right, a power nap.
Question comes in about children. Can they be put on an oil-free diet and put them on fats in natural form? Really having challenges with my family to convince. This is a challenge. If you're eating an added oil-free diet and you're having children, that should be no problem. You just need to make sure that you are getting enough fats in their diet, whether that is from beans and nuts and seeds and other things. That's quite easy to do, so that usually is not a problem. But if there are concerns, you may need to discuss them further.
There was a question on fruits. It's very interesting. My uncle had sugars of about 300 when I met him, and he was feeling very tired, and he was wondering, what can I do? My sister had visited me, and she was struggling with her own weight, and her cholesterols and lipids was pretty high. We put him on 3 days juice fasting, which she did it because she was also feeling guilty about it. And I was also trying to experiment to say, what does fasting does anyway? And this was juice fasting. That means instead of your food, solid meal, you just drink a glass or 2 glasses of juices, and it could be either a vegetable juice or a fruit juice. It finished on Friday, and Saturday, Sunday, 2 more weekends was there. So Monday we did the test. Her triglycerides from almost 350 had crashed down to less than 160. Cholesterol had come down by almost 30 milligrams, and sugars, which was almost touching baseline, she's not a diabetic, hit down to almost normal. And she reached to my uncle's place and she started advising. And you see, when he started juice fasting, we gave him even watermelon juices. I was expecting that would really push his sugars high, but the moment there's something about a fruit juice. Ideal is to take a fruit, but even if you took a fruit juice, as compared to when you drink any sugary beverage, you see sugary beverage with only sugar just pushes the sugars very high. As compared to that, a fresh fruit juice has many constituents which make sure that your sugars doesn't go up. That may vary from each fruit to other fruit. If you take the fruit whole with the skin along, the ones that you can eat with the skin, you see all the fibers, the minerals, the vitamins, apart from the glucose which is there, takes care that it doesn't spike as you would expect them to spike. So unless the sugars, if it is a little too high, you could check your sugars and see which fruits that you can tolerate. But the whole idea is to take fruits in its whole form, and it actually doesn't push your sugars very high. And we have been using a glucose monitoring, a continuous glucose monitoring, and we are discovering even chapatis that we felt was good actually spikes, because again, chapati is a wheat which has been processed, and so the smaller the grain size, the higher the glycemic index. And so the whole grain that you eaten whole, you find much better. And if you have to ask for any cereals, do contact Dr. Mohan. He'll provide you all the millets that is available. And now everybody is moving towards millets, because the sugar control is amazingly beautiful with all these things that we have stopped using and even stopped growing.
Gut microbiome, yes, we're learning a lot about it. It's hot in the literature. We are seeing that the microbiome may be different for someone who is obese, someone who has diabetes or other diseases, and if we are able to, we can, by adding more naturally fibrous foods to our diet, we can often help our microbiome, and we'll see in the future where some of those treatments also go. But the gut microbiome is a hot topic. What do we mean by plant sustainability?
Planet sustainability.
Oh, planet sustainability. What we see is that the more animal products that we eat, it takes more water, more land, and it turns out that the amount of land, I think it's up to 3/4 of all agricultural land, at least in the U.S. and maybe around the world, is to grow feed for animals so we can eat the animals. If instead of growing feed for the animals, we would eat that feed ourselves, that people say that could dramatically decrease world hunger. We also see that the animals require a lot of, are quite water intensive, and water is becoming more and more of a challenge for us around the world. It's suggested that some of our next wars will be fought over water, and we've already seen some of that here from even close by, that water is becoming more and more precious.
If some of you are wondering if you have diabetes and you really want to go all out and get the results that you're looking for, I would suggest now we have this continuous glucose monitoring. All that you have to do is fit in the sensor, and you can have a reader so that you can monitor your sugars. And if you are ready for it, one option is to go for 3 days of juice fasting. You can take a combinations of vegetable or fruit juices and keep monitoring your sugars. You can stop all your medications with that. And as you do that, keep monitoring your sugars. One thing that I found was helpful with juice fasting, I never believed in fasting, and that fasting never crossed my mind till I tried it. And what I felt was, most of the people feel they cannot live without their regular food. And how can I not eat? How can I skip that meal? How can I reduce the amount of food? There's a lot of psychological barriers when we talk about diet. What fasting does is it stops all your food. And if you survive by the end of the day, the person himself is surprised that, oh, I didn't eat a single solid meal and I'm still alive, standing and walking and not feeling exhausted, dizzy, ready to collapse. You see, it boosts up a very strong psychological sense in them that you can actually fast. I think those who fast regularly, you would know it, but those who haven't ever, it is a good psychological boost to say you can. And they're not fasting typically because they are taking some juices, so that still gives them some energy, so that you don't want to just keep them off the medicines. But if you do that for 2 or 3 days as much as you can, and feel confident within you that you have a control over your food, and that is not causing you to experience anything abnormal physically, then rest of the manipulations of the food becomes much easy. Because at this point of time, most of the people who are asking or wanting to do have a lot of queries, questions, apprehensions. What will happen? Will it be safe? Something bad will happen to me? Will I be able to do it? So this fasting, what it does, it helps you to gain that confidence that we really don't need so much that we take every day, but just that because we are used to it, it's built in our mind that if I didn't have it, I feel something missing and I feel abnormal. So something that helps us to do it. And so from that point of view, I have found fasting as a way of inducting a person as they begin this journey of changing their lifestyle. And as Dr. Herb says, sometimes we may want to start dramatic or drastic. Other times we may want to go. We would leave that for each individual to make up the mind and begin, and we all are happy to help out. So juices, as I said, you can take sweet lime, you can take even watermelon. We have found doesn't really cause much spikes in sugars. Beetroot, cucumber, among the vegetables are definitely safer. You wouldn't be expecting much spikes on that. So you can try different combinations of that. And then while you're able to sustain it, feel good. Most of the people end up saying that actually I'm feeling light. My uncle, I'm just giving a narrative about him. He's a foodie. He's really a foodie. So morning he skipped, afternoon he skipped. By evening there was some food passing in front. He almost stopped. He actually stopped him and said, "What is it?" "Okay, what is it? Just want to taste it." And I could make it out that he was really hungering to take something. And then his sugars went up. Next day, he said he felt bad about it. Next day, he felt. Evening, again, he had an urge to eat. But when he checked his sugars from 300, it had come down to about 150. And he didn't believe that his sugars could come down, and that is on no medicines, that he felt very kind of a confident and assured that, no, I will stick to it, and he skipped. And next day, the third day, when I watched, food went before him, and I could see that he had no urge to check and eat. And he actually said, I'm feeling very fit, I'm feeling light, my energy has come back because his sugars had come down. And he says, I can go for a few more days. So what I'm saying is that these are some narratives and experiences that people have. It all depends on, are you convinced? Are you motivated? And you need to have a support system, somebody to support you. And I'm sure with God's help, you can do it and change your life and experience something very different, something very unique, something very refreshing in your own body, in your mind, and look at life much differently.
Regarding glycemic index, this is something that we as doctors need to be thinking about. It turns out that if we're eating a high fiber diet, and today we've heard about someone that has been Dr. Lackey, who's been recommending 75 grams per day, and some of us are only getting 10 or 20 or 30 grams per day. There's also a move to increase our fiber intake to at least 50 grams a day. If we're getting enough fiber, we probably don't have to worry much about the glycemic index. In fact, the glycemic index is no indication about getting help for our insulin, for our insulin resistance. So if I have a patient who has uncontrolled blood sugars or is insulin resistant, I try and put them on a strong lifestyle program first, at least for a few days to a week or two. If they're really intent, after a week, maybe I'll tell them, if you want to eat a bowl of fruit of your choice, no problem, but first eat the same size of bowl of rajma or other legumes or pulses. And that often is very helpful. We do not find that the issue of glycemic index for fruit really makes that much difference. But again, anyone who's thinking about fasting, whether it's a vegetable juice or other juice fasting, etc., we need to make sure that they follow closely with their doctors, so that, especially if they're on insulin or medications, so that they don't run into trouble.
Just want to say, you are 80 of you still there. I really appreciate all of you. We'll finish here. Just the last question which is there. We would like to respond to that. The question is, any yoga benefits? Any suggestions to perform yoga or exercises? Now, yoga has two forms. So one is that of an exercise, which is mainly posture and stretching. And the yoga has meditation. And there are different ways that people meditate, reflect, and feel relaxed. So again, there is definitely a role of relaxation of the mind, as I mentioned, and different people would like to meditate and use different relaxation techniques. and any relaxation technique that a person is comfortable with is something that is definitely useful. So answering to that questions, people who believe in yoga would want to do yoga will have a beneficial effect. Keep it in mind, one thing I would point here, that nothing is, there's no magic or mantra in something that you do as a repeated. I would say there should be an understanding of what you do, and with an understanding and belief when you do a particular thing, it has definitely a benefit. So if you do an exercise, you're convinced about it and you do it, you'll definitely find what you should eat. I would say, let me put the diet in perspective. The diet is something, I have had patients which I have put them on diet. After 6 months, they come back and say, sir, can we eat what you had asked me to stop? And I look at the person very sympathetically. I feel very guilty that I have put him on a diet which the person is struggling with. So it's my mistake maybe of asking him, so if you do a dieting as a therapeutic modality, I can assure you it won't help, because you'll go back to what diet you had. So you have to understand, and right in the beginning I said the standard diet is a very nice nomenclature that the Diabetic Association has put in, that you call it reversal when you can go back to your standard diet and have a normal sugars. What we are saying is, in this pandemic we are talking about new normal. So what I'm saying is, what diet we are prescribing should become your new normal. Because only if this becomes your new normal and becomes your standard, you are moving towards reversal. Let me assure you that the reversal will happen. If you take this as a new normal, your sugars will be normal, you will never require medications and any other complications of it, if you are making a change much before the beta cell function is completely lost. So it is definitely possible. There's no standard diet that you have to go back on. Your standard diet will become a new normal if you understand the benefits of diet, exercise, and a mental rest in whatever way that you can get it. So I think I would close with that over here. I'm sure we can sit here for the whole night, and most of you will have a lot of questions. So I just want to thank each one of you. My participants have been a lovely group, and you stayed so long, and your patience is really appreciated. I hope we have shared something of useful to you, and thank you once again from our side.
On behalf of the Department of Medicine, I would like to thank both Sam and Herb. They have clearly put in a lot of effort, and this is something they passionately believe about. I thank the audience for patiently being with us this time. If you have any further questions, please feel free to mail Sam or Herb at med4@cmcvellore.ac.in. Again, thanks to Mohan and the team for arranging this talk. Lastly, next Friday, we have Dr. Vivek Matthew, Head of Neurology, Professor and Head. He will be taking a session for us on approach to people with cranial nerve palsies. It's maybe a more medical related for not just exam, but also for all clinicians, it will be useful. So we hope to see you there. This session has been recorded, and on our YouTube channel or on our homepage of the Department of Medicine, you can see this video probably in a week's time. So for those who missed it out, you can share the message that you can see this in a week's time. So with that, thank you all and have a very good evening.